Chapter 51 talks about diuretic drugs. While diuretics do increase urine production, and that's usually what we think of when we think of a diuretic, the diuretics mostly act to prevent the cells lining the renal tubules from reabsorbing sodium ions into the glomerular filtrate. This results in an excretion of sodium and water in the urine. There are 5 classes of diuretics, and each works in a different site in the nephron or by a different mechanism. You can see in figure 51.1 in your book exactly where each of these diuretics work in the renal tubules. Thiazide and thiazide-like diuretics, loop diuretics, the carbonic anhydrase inhibitors are mostly used as an adjunct to other diuretics, and we're not going to discuss those this semester. Potassium-sparing diuretics and osmotic diuretics are the classes we will talk about. The indications for diuretic use include edema associated with heart failure, acute pulmonary edema, liver disease, renal disease, hypertension, and conditions that cause hyperkalemia. First, let's talk about thiazide diuretics. Hydrochlorothiazide, or HCTZ, is one of the most commonly prescribed thiazide diuretics. These drugs inhibit reabsorption of sodium and chloride in the distal renal tubules, which increases the excretion of sodium, chloride, and water, and prevents reabsorption into the vascular system. Typically, patients with hypertension have one of their first medications to be prescribed as a thiazide diuretic. And they may also be prescribed for patients with heart failure, liver, or renal disease. Several adverse effects occur, the most important being that electrolyte imbalance caused by a decrease in potassium, as potassium is also excreted in the urine. Symptoms of a lower potassium level include muscle cramps, weakness, and some cardiac arrhythmias. GI adverse effects include a GI upset, nausea, and maybe a dry mouth. Neurologically, patients can experience dizziness and vertigo and orthostatic hypotension with the excessive excretion of water as part of the diuretic process. If the patient also takes digoxin for their heart condition, they do risk experiencing digoxin toxicity, and we will talk about that in an upcoming lecture because of the changes in the potassium levels. The cross allergy with sulfonamides is considered mild, but often patients who have an allergy to sulfonamides are not prescribed these drugs because of that cross allergy. The loop diuretics inhibit reabsorption of sodium and chloride from the loop of Henle and the distal renal tubular. They mobilize excessive fluid to be excreted. Furosemide and bumididine are the 2 examples chosen from this class of drugs. They are prescribed to patients with heart failure to help decrease edema and for patients with hypertension to decrease the blood pressure. Again, neurologic symptoms include dizziness and vertigo, orthostatic hypotension, and the electrolyte imbalances are also prevalent as adverse experiences, and patients should be monitored for their electrolyte balances while they're on these medications. A decrease in potassium, increase in glycosuria with long-term use, increase in liver enzymes, and elevated BUN can indicate that the liver and kidneys are being affected by a loop diuretic. Polyuria, again, because of the excessive urine excretion as sodium and water are excreted. And patients on loop diuretics can exhibit some ototoxicity or some hearing loss if this drug is given IV too rapidly or at a very high dose. Again, loop diuretics also have a cross allergy with sulfonamide and the thiazide diuretic, so you have to give these with very much caution. If you give a loop diuretic with an NSAID, you decrease the effectiveness of the diuretic. So patients are often asked not to take an NSAID while on their loop diuretic. You should not take a loop diuretic if the patient has an alcohol tolerance or if they have severe liver disease. And again, patients on loop diuretics increase risk of DIG toxicity because of that potassium depleting effect of the diuretic if they're also on digoxin. For individuals who are older, they have an increased fall risk for several reasons. One, because of the dizziness and orthostatic hypotension, and two, for the polyuria, because if they take their loop diuretic too late in the day, they tend to have nocturia, and trying to get up at night and get to the bathroom in a hurry puts them at a higher risk for falling. Potassium-sparing diuretics are not as powerful as loop diuretics. Patients retain potassium rather than excreting it, and these drugs are used for patients who are at high risk for hypokalemia, those patients who are also taking digoxin or who have cardiac arrhythmias. The example of a potassium-sparing diuretic is spironolactone. It is used to manage primary hyperaldosteronism as well as the edema associated with heart failure, cirrhosis, and nephrotic syndrome. Again, potassium-sparing diuretics are used for essential hypertension, meaning that hypertension without an underlying known cause, and treatment of hypokalemia because it counteracts the potassium loss caused by the other diuretics. This adverse symptoms, again, as for the other diuretics, dizziness, headache, arrhythmias, GI upset, and you can develop hyperkalemia because the potassium is spared and kept into the system, hyponatremia, and metabolic acidosis. There are some hormonal adverse effects that could potentially occur for the patient taking spironolactone, and they include gynecomastia in men, erectile dysfunction. Women could develop breast tenderness and irregular menstrual cycles, and can also experience deepening of the voice and increase in their hair growth. They may develop agranulocytosis or in a skin condition called Stevens-Johnson syndrome. The important part of taking care of an individual with any diuretic is monitoring their fluid and electrolyte balance, and you need to always assess the patient's potassium level before giving one of these potassium-sparing diuretics. Normal potassium, in case you've forgotten, I have listed here as 3.5 to 5 milliequivalents per liter. So making sure that the patient's potassium level is within this normal range prior to administering the potassium-sparing diuretic is very important. You also need to monitor the patient for EKG for signs of hyperkalemia, which would be seen as a tinted T wave, and the T wave is that portion of the EKG that indicates the resting period of the heart, and you'll learn more about that when you get to med-surg and learn EKGs. Teaching for these patients who are taking potassium-sparing diuretics, including avoiding salt substitutes, because salt substitutes are very high in potassium. They should also avoid high potassium foods such as bananas. So while the patient who's taking a loop or a thiazide diuretic where they're losing potassium all the time need to eat their banana, eat their kiwi fruit, they still should not use salt substitutes, but you encourage those patients to eat high potassium foods. With a potassium-sparing diuretic, it's important to tell them to avoid those high potassium foods because they have the potential to develop hyperkalemia. And finally, the osmotic diuretic is mannitol. Osmotics pull water into the renal tubule without sodium loss. Mannitol is a sugar that is not well absorbed by the kidney, so it pulls fluid into the urine. It is the diuretic of choice for increased intracranial pressure and acute renal failure that is due to shock. The adverse effect of this drug is related to the sudden drop of fluid levels. Patients may develop confusion, blurred vision. They may have some transient volume expansion, which would result in some hypertension. Electrolytes, they can become very dehydrated and either have hyper or hypokalemia and natremia. Mannitol is particularly irritating to the vein, and so you may have some irritation at the IV site, and if the IV infiltrates, you can have extravasation. The time you would not give mannitol to a patient who has increased intracranial pressure would be if that increase in their pressure is related to active intracranial bleeding. You need to monitor serum electrolytes and renal function. Mannitol is only given IV. The IV tubing must be filtered, and if you see crystals, then you're going to have to order the fluid. So you always check that IV fluid to make sure you don't see any crystals. There are some important sidebars in this chapter, including the focus on drug therapy across the lifespan, on safe medication, explaining fluid rebound, on potassium-rich foods. So you've got that nutrition reminder for patients who either need to eat potassium if they're on a loop or thiazide diuretic, or to avoid extra potassium if they're on a potassium-sparing diuretic. And the critical thinking scenario, which puts this all into practice, is identified as using furosemide in heart failure.